All right. Good day, dear listeners. We are starting immediately. You're welcome to our webinar presentation today from the Limi Children's Hospital in Abuja. Well, I'm Dr. Igor Chepita, consultant pediatrician and pediatric cardiologist. And with me today is Dr. Suberu. Dr. Suberu, welcome.
Thank you very much.
Yeah, thanks. So what do you have to tell us today? You look loaded with stuff.
Well, today we'll be discussing pediatric heart failure with emphasis on evaluation and management.
Yeah. It's all right. Fine. So we get to hear parents from time to time ask, do children have heart failure? But I'm sure our participants know that children have heart failure. We'll start with some case presentations just to ginger us up as we follow. So we have four cases,
Selected cases.
four selected cases that we managed successfully that were in heart failure. So the first one is a 10 male neonate who was seen in our emergency pediatric unit. Yes, he had mild heart failure, who had basically meconium aspiration syndrome. This triggered persistent pulmonary hypertension of the newborn, and the child from echocardiography had a mean arterial pressure of 27.02 millimeters of mercury. Other echo findings include atrial septal aneurysm with a patent foramen ovale. Like we said, the trigger of the heart failure in this boy, this neonate, was meconium aspiration. Basically, the care was supportive and including continuous positive airway pressure. The child survived. That's the success story. The other three cases actually have severe heart failure. Well, the severity of heart failure will be made clear in subsequent slides how we grade heart failure. We do not grade like adults who use New York Heart Association, but you will get to know. So a 1-year-old boy who stayed in the hospital for 2 days with severe heart failure had congenital heart disease. The trigger factor was that the right ventricular outflow tract obstruction was getting more severe. We managed on diuretics. The child survived. Also, we had another 2-year-old child who had congenital heart disease in the setting of Down syndrome. This child had unfortunately tilted to the Semenga syndrome before surgery was done somewhere else. Now, at the point we saw the child, echo that was done in our center, child had severe pulmonary hypertension with a mean pulmonary artery pressure of 53.6 millimeters of mercury. Surgery was not complete. He had a residual 3 millimeter cleft in the anterior leaflet of the mitral valve, and the right heart chambers were markedly dilated with global right ventricular dysfunction. The trigger for heart failure in this child was bronchopneumonia, and the child was managed on antibiotics to take care of the pneumonia, sildenafil for the increased pressure, and diuretics to reduce preload. The child survived. Now, we find a lot of children with sickle cell around, and then we wonder why we have a case of sickle cell presenting in heart failure in this case. So the child had severe anemia. Well, packed cell volume of 17.3. Well, although definition will say 15 and below, but when it's this low and it's symptomatic, it qualifies for severe anemia. Also had acute chest syndrome. Child had.
In addition, heart failure is not surprisingly rare in sickle cell patients because they are prone to chronic anemic states, and occasionally they can actually present in heart failure.
Yes. So this child had two comorbidities that triggered the anemia and acute chest syndrome. For the acute chest syndrome, we did an exchange blood transfusion, and the child was discharged the next day after the exchange transfusion. Child was commenced on hydroxyurea therapy, and the child survived. Now, we would want Dr. Zberu to let us know exactly what we hope our listeners will pick from the presentation today. The next Yeah. So what do we expect our
Well,
listeners to get?
thank you, Dr. Kuka, for the introductory talk, basically. And going forward, we are expected to understand the concepts and the types of pediatric heart failure, the causes of heart failure in children, as well as the clinical manifestations, and also the management of heart failure in children.
Oh.
And so, what is heart failure?
Yeah, so before that, when we talked about causes, you see, the previous slide we talked a lot. One child had bronchopneumonia, another one had anemia, another child had acute chest syndrome, the other two had congenital heart disease, the other child had meconium aspiration syndrome.
Yeah.
These are possible causes, triggers, which we shall
It
see.
also shows that heart failure can affect any age group.
Yes, yes. Okay, fine. So let's know what heart failure is.
Okay, heart failure basically it's when the cardiac output is inadequate to meet up with the metabolic needs of the body, and then it's a common outcome of many conditions affecting the heart in children, irrespective of the initial cause. On a chronic state, the end pathway it's similar, and then so this happens despite a normal filling pressure, which is the main difference between cardiac failure, heart failure, and hypovolemic shock in children, where the filling pressure is reduced.
Yeah, yeah. I remember in hypovolemic shock, which could result from either hemorrhage
Yes.
or dehydration, the central circulating blood volume is less. So when diastolic volume is less, and so output is less. But in heart failure, central circulating blood volume is the same, but there's a problem with
The
meeting
pump
metabolic.
action of the heart.
Yes, yes. Okay, fine. So let's see the causes and how it differs according to geographic locations.
Well, heart failure, the occurrence of heart failure in etiology differs across geographic locations. In advanced worlds, in the developed world, it has been shown to be commonly due to congenital heart diseases and cardiomyopathies. However, in less developed countries, Nigeria, which is one of them, it's commonly due to infections, malnutrition, um, asphyxia. And in Nigeria here, it's mainly following non-cardiac causes, severe anemia, especially following malaria infection because of the increased burden of malaria infection in our environment. And amongst other infections, pneumonia is one of which, sepsis, and then asphyxia. We also have the less common causes as seen in the developed world, which includes congenital heart disease, rheumatic heart disease, cardiomyopathies. However, rheumatic heart disease is not common in the developed world. It's a problem of the low income countries.
Yes, okay, fine. So if we look at this rheumatic heart disease, commonly the sequelae of
Yes,
acute
acute
rheumatic
rheumatic
fever.
fever.
So when we treat children with pharyngitis, we let them know that this group A beta hemolytic streptococcus pharyngitis
And
A.
this
Yeah.
and this you have mentioned is also helping us to create an awareness on the management of pharyngitis. As
Yeah.
much as possible, we should manage pharyngitis adequately, and so that because we're not too sure of the initiating agent, it might be strep, it might not be strep. But whatever you're dealing with, as much as possible, try to treat completely and cancel the individuals, especially if they are within the range 5 to 15 years, which has been shown to be the peak age for acute rheumatic fever. So they need to be cancelled to properly use the medication as prescribed, and it should be well prescribed
Yeah.
so as to reduce the long-term effects of acute rheumatic fever and rheumatic heart disease.
Okay, so adequate treatment therefore means the adequate dose, like
Yes,
basic first line penicillin base, and it must up to be up to 10
10
days
years.
treatment. Yeah. Treatment must start as early as possible.
You need to
Well,
have a high index of suspicion, especially when you
yes.
have children between 5 to 15 years.
Yeah, so when we're talking about the non-cardiac causes, severe anemia, most children are already walking around with borderline
Anemia.
PCV, borderline anemia, and by the time malaria trips in or an infection,
And then
malnutrition,
malnutrition.
yes, so the blood levels, part cell volume drops further, and unfortunately, these children will not be able to compensate. And, yeah. So, but coming to congenital heart diseases, as we practice, as we get more advanced, we get to see them more commonly.
Yeah.
Because 2 out of the 4 cases that were earlier presented were children who had background congenital heart disease. So if we look at congenital heart disease, of course, various types. But the thing is, whatever makes cardiac output less than sufficient for meeting metabolic needs. So now you see, cardiac lesions that have left to right shunt blood away from the left chambers, which should supply the body for metabolism. So a child with a large ventricular septal defect, a very large atrial septal defect, AV canal defect, patent ductus arteriosus.
Yeah, there are several of it, actually. Even the obstructive lesions too can eventually lead to heart
coarctation
failure.
of aorta. It's all right, fine. So that's a good work on the etiology. So let's see classification. So we look at classification. How do we classify them?
But there are various forms which you can classify heart failure. It could based on the cause of the disease, where you say acute and chronic. Acute causes are mainly secondary causes, like a child who had anemia and then had heart failure. You're dealing with acute heart failure in that point, or a child who had pneumonia and then slips into heart failure. So once you're able to treat the underlying cause, most times the heart failure resolves and that is it. But for chronic heart failure, as the name implies, it's chronic. It's something that is long-standing, and this is mostly due to cardiomyopathies or a child who had a congenital heart disease, where you have a primary lesion involving the heart. So you're in heart failure for a prolonged time, and that's what stands on chronic heart failure. Could also be determined based on the severity, and this is actually a child who is in heart failure and you want to know the degree or the degree of severity really. So it's from mild to severe, and there are certain parameters actually used to describe this, and this will be discussed in the course of the presentation.
Yeah.
Then could also be classified based on the cardiac output. Like we mentioned, the cardiac output is insufficient to meet the metabolic demand. And so what already comes to mind is the low cardiac output when you mention heart failure. But there are times when you have a high output heart failure. And what really happens here is there is an increased demand from the body or by the body, so to say, such that what is supposed to be a normal cardiac output becomes insufficient. And even with compensatory actions of the heart to increase the cardiac output, increasing the heart rate, increasing the stroke volume, this is still insufficient to meet the metabolic demands of the body. And these states are usually following a diseased process. Example, we have in anemia, in arteriovenous fistulas, even in sepsis and some other conditions, yes, and even in hyperthyroidism. It's primarily because of the increased demand of the body. That's why the heart is not able to meet up. Not necessarily because the output from the heart is not normal.
So, for example, a child with severe anemia, the blood volume is still constant, but hemoglobin levels are low. And the heart is pumping so fast.
Yes,
but oxygen delivery from hemoglobin is below expectation.
Yes,
so that's clear.
Because of the low hemoglobin levels, there's tissue hypoxia. And this sets in some mechanisms. And the heart tries to compensate by increasing the heart rate, increasing the stroke volume, but still this does not get to meet the demands of the body. And that's primarily because hemoglobin, which is the oxygen transport, is reduced. Yeah, so that has to be corrected for you to be able to take the child out of heart failure.
All right, thank you. Dear listeners, we want to be very sure that we are audible enough. Please let us know if you can hear us. All right, thanks. So into the chat box, you could be putting your questions so we will address them as we go or terminally by the time we round up. All right, fine. So if a child is in heart failure, how does the child present? Most people, of course, are more conversant with the way adults present in heart failure, but
yes, the presentation differs to some extent depending on the age of the child and then the causative agent or what is primarily responsible for the heart failure. But generally, in young children, they present with tachypnea, and this is not unexpected because we just mentioned they present with tachypnea, they present with feeding difficulty, especially if they have an underlying congenital heart disease because of there might be some congestive symptoms, which is with that there is reduced tissue oxygenation, and then there's increased respiratory rate so as to increase the oxygen delivery to the tissues. And feeding difficulty, yes, this is because feeding, especially suckling action, is serves as a stress, poses a stress to the child. And
Yeah.
for a child who already has a background heart failure, it becomes difficult for this child to feed. As they attempt to suckle, they just do this for a couple of minutes and they take their mouth off, trying to pause and then catch some rest before going back to feed. And also because of cardiomegaly, they can have reflux. In fact, we've had some kids who had reflux that was very bad and had to have a surgical procedure put in place so
Yeah.
as to optimize calorie intake in the child. Could also have diaphoresis.
Okay, so just before you continue, you see, so far the presentations, manifestations that have been discussed have to do with activity. Feeding is one of the most conspicuous activity that these babies would have. Unlike adults that may jog, may go for marathon, these babies feeding consumes a lot of
Yes,
energy.
yeah, actually
So
easy fatigability.
yeah, they get easily fatigued, and it's a marker which we'll see in about the next slide when we start grading heart failure, especially in these children. All right.
Okay, so there's also diaphoresis pallor. This is actually following the increased catecholamine release, which occurs in as part of the compensatory mechanisms that the body puts in place. Once there's reduced tissue oxygen levels, the compensatory mechanism is activated, there's increased catecholamine levels. There's also the RAS system. And all of this is needed to increase the heart rate and as well increase the stroke volume and trying to meet up with the oxygen demand of the body. So this can explain the diaphoresis and pallor. Then in older children, they can have symptoms similar to what we have in adults, and this includes easy fatigability, effort intolerance, dyspnea because of the pulmonary edema, autopnea, abdominal pain, mostly from the um, enlarged liver, the hepatomegaly, and then nausea and vomiting, which is also because of the hepatic congestion.
Yeah.
And then the less commonly encountered symptoms could be syncope and features of systemic and pulmonary, systemic venous congestion like facial edema, dependent edema. Children, in young children, is dependent, and if for a child who is mostly lying down, you are likely going to pick a sacral edema earlier than a pedal edema. Could also have ascites, and then
Yeah, so about the edema, the capsule around the liver is still more, the Gibson's capsule is still more elastic in children. So the backflow that would have caused the preload would have caused edema. Fluid now is accumulated around the liver, and so the liver enlarges. So liver enlargement is of more importance in checking dependent edema compared with pedal edema as commonly found in adults.
okay, so would also have the palpitations, chest pain, and
Okay, fine. So having said this, I'm sure our dear listeners can suspect heart failure in children, but let's see how do we now grade heart failure in children. I started by saying we do not use a New York Heart Association classification that our elder brothers in adult medicine use. We rather use a ROS classification. So ROS classification have actually passed through various stages of modification.
so why are we not using the new?
All right. So the New York Heart Association classification is actually based on limitations to physical activity.
It was actually
in
primarily
adults.
designed for adults.
Yes, originally
so there's
designed.
a limitation to
Yeah.
its use in children.
Yeah.
Although at the time that was what we were using before the ROS classification came out.
Yes, yes. So you see, heart failure, there is decreased activity. But what is the marker of activity? Now that changes with age. That's age dependent. So whereas for the adults it's physical activity, we shall see in the ROS classification that in infants and children we have other modalities to check those symptom-based manifestations of
and there are
activity.
scores attached to each of the symptoms depending on the degree.
Yeah.
And then cumulatively, this is calculated, and you're able to classify the child appropriately.
Yeah, so we have from no heart failure to mild heart failure to moderate to severe. So the question, if I was a participant, I would ask is, so where is that diagnosis doctors commonly make that impending heart failure? Because it's either no heart failure or mild heart failure, moderate or severe. So please, the ROS classification gives no space for impending heart failure, which is a very common thing we see. So let's look at how ROS did the classification. So it's classified based on age, like we said, because the parameters to check physical activity is age dependent. So now we give a score of 0, 1, or 2. So take for a newborn baby till the age of 3 months, if we check the amount of feeding, this is feeding assuming the baby is bottle fed. So if we check the O's, if we convert to liters, the baby that can take, so the more the baby can take, the better the function because feeding. So about 3.5 O's is like
About
100 meals. Yeah, so the baby should be able to take more than 100 meals. So the baby is taking between about 75, between 70 and 100. Let's see about 1, and this is below that amount. Well, you find some children who at this point, I'm not hungry and I'm not ready to feed. So will you give 1? Well, that's not standalone. Let's see. Let's look at the other.
So it's not a one-time feeding that will be used to classify it. It has to be something consistent.
Yeah. So mind you, the no heart failure, it's even 0 to 5. So a child could score up to 4. The child is not in heart failure. So time of feeding. The child that feeds so long, sucking now, may really not be getting enough. So the child sucks, pause in between, continues. This child is hungry, but the child doesn't have enough effort, so it's prolonging. So we look at the duration of feeding. Then breathing, is it normal? 0. Is the child tachypnic? The child that is tachypnic has a score of 1. It's worse if the child has retractions. So retractions it's more severe. We now come to respiratory rate. This is where detailed clinical examination becomes important. So respiratory rate should be less than 50. Well, if between 50 and 60, more than 60, then it's 2. So we now look at heart rate, we check perfusion. Perfusion, you check from capillary refill time. If it's reduced or it's far much prolonged, that's for shock, that score of 2. Now, hepatomegaly, the ROS classification, again, back to our traditional teaching, what we used to know about hepatomegaly, we hear tender hepatomegaly. But from the ROS classification, we are restricted to hepatomegaly in the setting of these other parameters. So if a child has enlarged liver of less than 2 centimeters below the right costal margin, 0, most times that's okay. But between 2 and 3, well, 1, then greater than 3 is always a problem. Okay, so we also check the anti-pro.
That's the pro-BNP, brain natriuretic peptide.
Natriuretic peptide.
Yes, actually, it's one of those things that's secreted following stretch of the ventricular muscle. And there are other natriuretic peptides, the AMP and then the BNP. But for the purpose of ROS, it has used the pro-BNP, but you can also use BNP. And the thing is, when you have congestive heart failure, because of the muscular stretch, there's increased release of this peptide. So the degree of rise is also commensurate with the degree of heart failure in the child.
Okay. So see, the higher the values, the more severe it is. So I've heard people ask, so should you do echo for children in heart failure? Well, we check the ejection fraction. So we have ejection fraction above 50, that's okay. Although we know currently we want cutoff of 55 and above, but above 50, fair enough. But by the time ejection fraction, left ventricular systolic dysfunction is setting in, then there's problem. Also, we check the aortic valve for incompetence. So no aortic valve incompetence, mild and severe. Now, great. So by the time we grade all this, we score this for a child between 0 to 3 months. Let's go back. If we find a score of 0 to 5, the child is not in heart failure. If we find a score between 6 and 10, then it's in mild heart failure. Then moderate and severe as we find. So let's see, check the next age, between the age of 4 months to 1 year.
I think most of the parameters are similar.
Yeah.
The main difference you're checking for is this time around you're not quantifying defeats.
Yeah.
So it's either is it decreased or
Subjectively. So the
Yeah.
mothers can tell if subjectively,
Yeah.
oh, feeding has decreased, not feeding as it should. And then this calls to the reason for continuous weight monitoring.
Yes.
Like during immunization, every child should have a growth chart according to the various percentiles.
By the time a child is faulting,
Growth faltering.
yes, you want to look out for what could be the reasons. At times, these children, the mothers might not pick it on early that this child has an issue. They could notice the fast breathing, but never really paid attention to it, especially from a parous mother.
Yeah.
But when they come in for immunization, some of these things can be picked and then they are directed appropriately. I once had a child, was a 2-month-old, came in for the 6-week, was it either 6 or 10-week schedule of immunization, and then the attending health worker noticed the fast breathing and also noticed the weight was a little less than what was expected and sent the child to the emergency pediatric unit. And surprisingly, this child was in failure. And by the time we did an echo, this child actually had a double outlet right ventricle.
Wow.
So you can see how some of these steps, how it goes a long way to help some of these babies.
Okay, so now a little more on double outlet right ventricle. You know, commonly there will be an associated ventricular septal defect, and shunt lesions become active at about 8 weeks
6
upwards.
weeks.
Yeah, 6 to 8
When the
weeks.
pressures
Yeah.
are
So when the right sided
pulmonary pressures.
where pressures are dropped. So that's a critical time we pick shunt lesions a lot. So the parameters are here as stated. We use them to grade them. Also for children who are between 1 to 3 years, essentially we look at these parameters and we grade. Then same for 4 to 8 years. Now 9 to 18 years, almost like adults, adolescents, and 18-year-old is between adults and pediatrics. So these parameters tell. So we find breathing, normal breathing, and all these parameters we check. Now, we see the maximum percentage of predicted maximal oxygen uptake, as is stated. So
yeah, let me just say 1 or 2 things about this. Okay, we'll discuss it in the course of the presentation.
It's all right, fine. So this essentially is the age-related modification of the ROS classification of clinical severity of heart failure. I think this should be a good take-home point for our listeners today. So how do we investigate children in heart failure?
Okay, starting with the initial history and examination, where for some reasons you're able to you're able to detect that this child is in heart failure, because heart failure primarily is a clinical diagnosis, and the investigations you're doing is mainly supportive and to rule out or look out for what could have been responsible for it. So chest X-ray is one of those things you want to do. Chest X-ray, basically, you would have features of cardiomegaly, and there's a way which is calculated, the cardiothoracic ratio. And then in addition, you could also, depending on the type of congenital, if there's a congenital heart disease, depending on the type of congenital heart disease, you might have some peculiar shape of the heart to tell you, okay, this is what you're dealing with, like a figure of 8 for a child with total anomalous pulmonary venous. Yes. And then in addition, the pulmonary, you could see evidence of pulmonary congestion on the chest X-ray. Then ECG.
Okay, so still on chest X-ray, because now you could have someone with completely normal heart. I know that in Nigeria, the commonest cause of heart failure in children, they are non-cardiac. So from the chest X-ray, we could see if we see evidence of severe bronchopneumonia,
Yeah.
even with cardiac shape, although size will be a problem anyway. But even if it has a normal configuration, but a lot of patchy opacities with air bronchogram sign, is pointing, confirming the pneumonia that should have been clinically suspected as the etiology of the heart failure in these children.
Okay, we could also have the electrocardiogram, which is ECG, and basically this records the electrical activity of the heart, and it's in addition to telling you what the problem could be, like for example, a child with myocarditis or even pericarditis, you might be able to notice this on the ECG because of the reduced amplitude
Voltage.
of the tracing in all leads. In addition, there could be chamber enlargement. There are certain parameters you see that would depict a right atrial enlargement or a left atrial enlargement or a ventricular hypertrophy. Then, more importantly, it's arrhythmias. You'll be able to pick this on the ECG.
Yeah.
Another thing you want to do is the echocardiogram.
Okay, sorry, still on ECG arrhythmia. So we once had a baby in our neonatal intensive care unit that was referred to us. That this child, they were treating for neonatal sepsis. The child was having persistent fast breathing. The child was just not doing well. And when we checked the heart rate, it was 220, and that was alarming. Quickly did an ECG and found it was supraventricular tachycardia. So it's important. The ECG becomes very important. One of these we should make a presentation on pediatric ECGs because probably it will be very interesting anyway. Yeah. So commonly echocardiography.
Yes, echo basically tells you the function, the structure of the heart, and you're able to see if there's any heart defects and if there's any complication. In addition, you also will be able to demonstrate the function of the heart, like you want to check for the ejection fraction, which is one of the parameters that you may be needing in, or you will be needing in classifying the child using the ROS classification. Then blood investigations that we can do.
Yeah, so still on the echo, so ejection fraction to tell us left ventricular systolic function.
Aortic valve.
Then aortic valve
insufficiency
becomes very, very important.
Okay. So blood investigations. The blood investigations, we've mentioned the brain natriuretic peptides earlier. We've mentioned the NT-pro, which is the pro-BNP. In addition, there are other things you want to do. That's the mixed venous oxygen saturation, which is what I said we were going to talk about earlier. And what happens with the mixed venous oxygen saturation? Basically, you are assessing the oxygen saturation in the systemic venous blood before it gets to the pulmonary for oxygenation. And that gives you an idea of how much oxygen uptake had occurred. And normally it's 80% and above. So once you have less than that, it tells you more oxygen has been taken in by the tissue, and indirectly it tells you there's a reduced cardiac output. Because if the cardiac output is normal, the oxygen getting back to the heart shouldn't be very low. Shouldn't be very low. So once it's very low compared to what it should be, it tells you there's been increased uptake at the tissue levels, and indirectly tells you there has been reduced supply to the tissues. And so in addition, other things you want to do, you also want to check the creatinine, because for a child in heart failure, especially chronic heart failure, there's been a reduced systemic flow to tissue, so there will be some form of organ injury and organ injury. So you want to do the creatinine and check to assess the kidney function. And then, so genetic testing is something else you want to do, but this is primarily for individuals with cardiomyopathies, because we know there's a congenital component to the occurrence of cardiomyopathy, especially in young children. And then cardiac catheterization. Cardiac catheterization basically is a procedure where certain catheter is introduced into the heart, and this is primarily to check the pressure in the heart, and there are some other things you want to check in the heart. So
I think there is a slide on cardiac catheterization. So you talk more about that. But basically, pressure changes across chambers, valves, and okay. But before we proceed, we have a question here. All right. Okay. Before we just want to re-echo it that we are audible enough. Is that right? Okay. Fine. So thanks. So we have a question from one Paul. Yeah. How do you differentiate facial edema in heart failure from acute kidney injury in children? How do you differentiate facial edema in heart failure? So this is quite simple. I'll talk about it then. Our presenter will also talk about it. Now, um, the edema in heart failure. Go, we're talking of children now. Children. So commonly is dependent edema, and the children would have liver enlargement at younger age. At older age, it would be pedal edema in adolescents. But facial edema is facial edema commonly with nephrotic syndrome, acute nephritic syndrome, which may proceed to AKI. The component of renal involvement in children with heart failure could be related to what we call the spectrum of disease, the cardiorenal syndrome. And usually there are 4 types of cardiorenal syndrome, type 1, 2, 3, 4, but, which we are not actually going into today. But facial edema, renal, dependent edema, hepatic in heart failure for children, pedal for adolescents.
I think I have an idea what this person is asking. In addition to the dependent edema, I probably also want to know the characteristic of the facial edema. Well, like it's been said, facial edema is not so common in children in heart failure, but even if they do, there's a general description that says for renal edema, it worsens as the day progresses. No, it reduces as the day progresses. Why facial edema due to heart failure worsens as the day progresses. And the simpler way is as the day progresses, activity increases, the heart is further worked than it's supposed to. And so this edema accumulates. That's the general description to differentiate these two. But ultimately, you still need your history, your clinical examination, because there are several other things that you would get from the history and examination that will tell you if you're dealing primarily with a renal issue or a heart issue.
It's okay. Thanks. I hope that throws some light to the question. We'll proceed. All right. So I said there was a slide on catheterization. So by the way, we have facilities for cardiac catheterization in one of the branches of our Limi hospitals, cardio care, which is a cardiac branch of the hospital. So a lot of adult cardiac procedures going on, including catheterization, and facilities are already on ground for the pediatric catheterization programs, which we hope to commence anytime soon. So it will be good that listeners hear us as we talk about cardiac catheterization, which we will, beyond theory, we will see it live in the next few days, few weeks in this branch. Okay, thank you.
All right, basically, like I mentioned earlier, it's an invasive procedure, no doubt, but it gives you more detailed information of what is happening in the heart, and it helps you to measure the pressure within the heart. We use echo to determine these pressures initially, but for more objective reasons, cardiac catheterization will give you a more objective finding than echo. And then it's also used to evaluate the arteries, because at times you could have some narrowing of some of these arteries. Cardiac catheterization will help us to evaluate the vessels of the heart and see if there's any narrowing or blockage. It could also serve as a means to get a biopsy sample, especially when you're dealing with cardiomyopathy and where you want to do some histology investigations. And then it could also serve as treatment, especially for those with some congenital heart disease and amenable to transcatheter procedures like the VSD, the ASD. This is one of such platform where it acts both as a diagnostic tool and a therapeutic tool.
It's okay. So that's interesting. This will be very practical soon in Nigeria from this branch. All right, fine. So we've talked a lot about the causes, how to identify, how to classify, how to investigate. Our listeners will want to know about treatment, the principles, the goal, the modality, the drugs, the algorithms. So we'd like to hear from you.
Okay, basically, treatment is dependent on the cause, or let me say the principles you want to treat the cause. Like we have highlighted earlier, there are several causes of heart failure, especially when it is one that is amenable to treatment immediately. So you want to treat the cause. If there's anemia, you want to transfuse. If there's an ongoing infection, you want to give antibiotics, or you want to treat appropriately. You also want to correct any precipitating event, like a child with a background congenital heart disease who was seemingly stable, but if the child has a pneumonia in addition, it can tilt the child to heart failure. So you want to correct any precipitating events. And then if there's any congestion, which could be pulmonary, systemic, and at times it could be both, especially when they have biventricular failure. So you also want to treat that too. And then the goal of treatment, like I mentioned, especially for those with chronic heart failure, is you want to maintain stability, and this helps you to buy time until the child is able to have the corrective surgery or take care of the primary problem. You want to prevent progression, and this is one of the reasons why certain medications are usually given in them. Medical treatment is instituted. Why this helps to um, relieve congestive symptoms. It helps to bring them to a near normal, stable state, and why preparations are being made for surgery and to minimize the progression. Because if surgery is not done, ultimately it will progress and there will be complications. So it's not like it completely takes care of surgery, trying when you have a congenital heart disease. You also
Yeah,
want to
yeah.
provide
So commonly when we do echo for, let's say, children with ventricular septal defect, we hear this question. So what do we do? And most times, since um, cardiac interventions are not yet common, although will soon be very common in this center, they get to ask you, how long can it take? What can I do? Okay, I will tell commonly, we'll give preload reducers, furosemide spironolactone. And you see this sigh of relief. So my child can be on it for years, for the rest, okay, without going for surgery. And I said no. It's basically to stabilize the child, to buy time before you go for surgery. So that's preventing, that's to maintain stability. Ultimately, surgery is necessary. Yeah.
Yeah, surgery
Yeah.
is necessary. So while you're at that, you want to provide a reasonable milieu to allow growth.
Yeah.
Because of the cost
Mm.
of heart failure, if care is not taken, this child would just keep expending energy and becomes very difficult
Yes.
to for the child to grow. So as much as possible, you want to take out or minimize stress. And for the young infants, you'd rather advise them to cup and spoon feed rather than to suck
Yes. Yeah.
directly. And so these are some of the things, and optimize nutritional intake, because for them they have an increased basal metabolic rate, and so the oxygen consumption in them is higher. So you need to optimize nutritional intake so as to be able to meet up with that demand and as well add weight, um, and as well be able to add weight, because optimal weight is also required for a good surgical outcome. So they need to have some degree of optimal weight for them to be able to go through surgery, except in emergency situations.
Okay, so talking about this weight, we're talking about growth. So there's need for growth monitoring because growth faltering can occur. These children can fail to thrive.
Mostly they
So,
fail to
well,
thrive
so
without it.
failure to thrive now, this is now organic. There's a reason, which until it's addressed. But let's talk a little about this weight, something you talked about. They wouldn't gain weight. So a child with a background cardiac problem, heart failure from background cardiac problem, is failing to thrive. The weight is below two standard deviations below the mean for age. So it meets the definition. But now the child is in heart failure now and is gaining fluid and has gained weight. So the weight increases, you see. So, but part of the management is elimination of the excess fluids.
Yeah.
Yeah. Okay. It's all right. Thanks. So let's see other modalities of treatment.
Yes, like we mentioned, it could be medical. Most times you start with medical, and then surgical, which is dependent on the primary lesion, and you may also need to do catheter-based intervention. Not all congenital heart disease are amenable to catheter-based intervention. So there are some you might just need to go ahead and do an open heart surgery. So we're basically trying to take care of the underlying cause, because if that is not taken care of, that child will not be able to come out of heart failure. And then the other supportive therapies.
Okay, so the catheter-based will maybe like some valve problem, pulmonary valve, some stenosis, aortic valve, where surgeons may be a little bit careful in sizing once needed. So a catheter-based procedure may be more appropriate than surgical in selected cases.
Yes, and even VSD closure,
Yes,
ASD
device
closure, device
closures.
closures.
Yes.
Okay, then the supportive therapy, in fact, we've talked about feeding.
Yes.
It's very key, because if you don't optimize intake, if you don't optimize nutrition, the, you realize they find it difficult to add weight.
Yes.
So you need to, it's something you have to be conscious about and pay attention to. And then other things you may want to do is continuous positive airway pressure, especially when they come with features of pulmonary edema. This goes a long way to help, or even if they come with pneumonia.
Yes. Okay, so oxygen therapy in heart failure again depends a lot on the primary cause. Granted, they need supportive care for which oxygen is part of it, but we like to be cautious in shunt lesions like
Yes.
ventricular septal defect, because oxygen is a drug and it's a pulmonary vasodilator. So there is already in ventricular septal defect, there's already left to right shunt. And then if you give so much oxygen, the pulmonary vessels dilate, and so the
And
lungs get flooded.
yes, it worsens the shunt.
Yeah. So cautious use of oxygen.
Yes.
But for the non-cardiac causes, I mean, oxygen should go liberally as necessary. Okay, fine. So let's see the various algorithms, the roadmap for heart failure treatment.
This is basically to serve as a guide, and it actually depends at the point this child is coming in. If the child is coming in severe heart failure, where the child is in obvious respiratory distress, the child is in obvious sweating, in obvious respiratory distress, and then features of heart failure, there's tachycardia, there's hepatomegaly, and then obvious signs of reduced oxygen, reduced tissue, obvious signs of tissue hypoxia. And so you want to ask me, how do you know there is tissue hypoxia? So these are some of the things you want to check. You want to check lactate levels. Like we mentioned, with tissue hypoxia, there's increased anaerobic metabolism.
Yeah.
So the blood lactate levels increases. In addition, is the mixed venous saturation, which I mentioned earlier, because with tissue hypoxia, there is increased uptake of oxygen from the blood. So the oxygen concentration of the blood getting back to the heart would be reduced. And then the BNP, we talked about anti-pro, yes, earlier, which is a pro BNP. We could also use the BNP. So the levels will be very high, and then the work of breathing, which is actually obvious to you. So these are some of the markers that tells you, or the indicators that tells you the degree of severity. And then you always fall back to your ROS classification. But by the time you look at each of these components, and then your clinical examination findings, you'll be able to classify the child appropriately. So a child with severe congestive heart failure, you want to commence the child on intravenous diuretic. Commonly we use furosemide here. And then we also want to commence the child on inotrope. So it's individualized. It's not all of them, but if the cardiac output is very low, especially if you do an echo and you have the ejection fraction very low, say less than 30%, you have to bring in an inotrope. And there are various kinds of inotropes you can use. You can use milrinone, you can use dopamine, dobutamine. You can also use the digoxin, although the digoxin is something we are beginning to shy away from gradually because of the untoward side effects
Yeah,
of the
very
jolting.
narrow therapeutic index.
Yes, yes. So, and then once you've been able to take care of the immediate needs of this child in the first 48 hours, you're trying to address danger signs. You also want to put the child on positive pressure ventilation, especially if there is pulmonary edema, because it helps with the pressure, it helps to push the fluids from the lungs. And then gradually you wean this child off into oral medication. So you could start by converting to an oral diuretic after 48 hours. You want to also bring in ACE inhibitors. Commonly we use captopril here. You could also use enalapril. However,
Yeah.
lisinopril is not familiar. The use of lisinopril is not common in children. It's mainly in adults. Then nutrition, you have to optimize nutrition. At this point, the child should be stable enough to eat, so you have to optimize nutrition. And then you may want to commence oral anticoagulation, but this is not across, but this is mainly for children with dilated cardiomyopathy, because with dilated cardiomyopathy, there's risk of thrombus formation. So
Yeah.
you may want to commence them on oral
Yeah.
anticoagulation, and
Yeah.
then
So the
you
just
work them
alluding
up
to
for discharge.
the risk of the necessity for the anticoagulation is because in dilated cardiomyopathy, the chambers are dilated. There's global hypokinesia, so blood can clot around places where blood should flow very easily. Global hypokinesia, systolic dysfunction, blood stagnates, blood now clots, and so you have issues with coagulation problems. So anticoagulation is essentially a
Yes,
necessity in
and then
such.
gradually you work them up for discharge. So you have to keep looking at your indicators in the course of treatment. You have to do the serial lactate levels, the serial um, mixed venous oxygen saturation, the BMP, and this is what will tell you if you are winning on this child or if you need to step up in the care of this child. And then even in spite of all you're doing, the cardiac output is still low, in spite of the inotrope, in spite of the IV diuretics, the cardiac output is still low, then you know you have to start going towards the escalation phase where you might require multiple inotropic supports and then invasive ventilation and as well mechanical circulatory supports. And while on this phase, if there's still no significant improvement, then it shows that hearts cannot be helped any longer. And that's the candidate for a heart
Heart
transplant.
transplant. Wow, we hope we don't get to that level because heart transplantation is another world of its own.
Yeah.
Yeah, other reasons for heart transplant, those who did not have surgery on time, the shunt lesions that shunt pressure reversal of flow, Esimenga complex. In such situations, you want to, if I want to do a heart lung transplant
Yes,
in such
because just
situation.
a heart, especially if it's in the early phase where it's reversible, you could still do a heart transplant and it will be sufficient. But if it's already in the irreversible phase of pulmonary hypertension, and just doing just a heart transplant will not help
No,
because the pulmonary vessels have already gone through the damages. So even if you do a heart transplant, there will still be a secondary affectation of the heart much later.
it's okay. So let's see
I
step by
think,
step.
yeah, this is basically to just corroborate on the previous slide. And a child is coming to you you've taken your history, examination findings, you think this child is in failure. So you're asking yourself, is this child hypotensive? Is there tachycardia? Is there respiratory distress, which will be obvious to you? And is there gastrointestinal distress? When you say gastrointestinal, it sounds funny, really.
Yeah,
It's
we are
not
used to
something we are
respiratory
used to.
distress.
Yes, but basically by the time you're having nausea, vomiting, and these are signs of gastrointestinal distress. So once you have none of this, you know this child is fine. And then you can just safely place the child on ACE inhibitors. Especially for a child with a background congenital heart disease, you can safely place the child on ACE inhibitors and that will be all. But if the child sorry, if you would have also done the EF, the echo,
Like rejection.
injection fraction is good, there's good right ventricular function, so you can safely place a child on ACE inhibitors. But in spite of the initial findings, but the EF is not optimal, and there is mild dilatation, you may want to add beta blocker to the initial to ACE inhibitors. However, if you have this child, you are not convinced, it's not completely no hypertension, no tachypnea, maybe some mild tachycardia or some mild respiratory distress, somewhere in between. The first thing to do is to start with diuretics, and you observe for 48 hours. And meanwhile, you're also checking the BNP levels, you're checking the other parameters. So once the BNP level is dropping and then the creatinine level is normal, then you move the child to class A. So class A, you go back to class A, you're checking, okay, if EF is fine, good right ventricular function, then just discharge on ACE inhibitors. Okay, but if with your diuretic therapy, the child is still having raised BNP levels, sodium level is dropping, there's increasing creatinine, it tells you there is worsening states, and so you transfer to class C. Class C is where you now have to go IV, you want to give IV diuretic, you want to give inotropic support. And you could have been in class C from the beginning, where you have features of hypotension, there's tachycardia, there's obvious respiratory distress, and so you start with IV medications, IV diuretic therapy. Yeah, you may need to give inotropic support, and you may need to give the positive pressure ventilation. So once you are doing this and the child is improving, you step down. So basically, the chart is to help you either to step up or to step down the treatment. By the time you have exhausted the IV diuretic, IV inotropic, and you are not winning, then you know you need to go for something high. You might need to do multiple inotropic agents. You might need to give a ventilatory support while you await heart transplant.
Well, it's okay, fine. So let's see the drugs common, just like the pharmacology of the therapy based on the various ROS classes. In this slide, the good thing about it is that I've tried to merge the ROS classes with the New York Heart Association classes. So let's see from
Yeah,
class
this
one.
the class one, which is step one, is no heart failure, and step two is mild, step three is moderate, step four is severe, and a bit on the pathophysiology, which I think I mentioned in the course of the presentation, but not so elaborate. Really, what happens with the kind of chronic heart failure? Because of the chronic heart failure states, there's some increased release of catecholamines, and then the RAS system is activated. So this primarily was meant to serve as a compensation for the heart to optimize the heart rate and the cardiac output. But eventually, this causes more stress for the heart because there will be increased oxygen consumption. The heart muscles are overstretched, they become hypertrophied. Yeah, they become hypertrophied so as to meet up with this need. But in the course of doing this, there's some myocardial death, some cardiac cell death, and then this become replaced by fibrous tissue, and cardiac remodeling continues. And with this, number of times the heart is seem big, but you term it big for nothing. Basically,
So when we
big,
hear,
but it's not
so when we hear people say
And-
he has a big heart, that the big heart in English is for English, but the big heart in heart failure, it's not.
Yes,
It's
okay,
bad.
so
Yeah.
that's why when the remodeling has set in. So basically, I had to go down this so as to explain why we are using some of these medications. ACE inhibitors, if you see, is expected to be used all through the phases. So you have a child who has congenital heart disease. You know this, even if the child is not in failure at the time you're seeing, but you know this child is at risk of failure, not just failure, but at risk of a chronic heart failure. So you want to commence the child on ACE inhibitors, which has been shown to reduce the remodeling, the cardiac remodeling that occurs. So another thing that is gaining or that has gained popularity is the use of beta blockers because
Okay, sorry, the ACE inhibitor. That's why we commonly place on the nalaprio,
yes,
Yeah.
or captopril.
captopril.
Yes.
Okay.
So beta blocker is another agent that is also being used, is being tried in adults. It's also currently being advocated for in children. And there's a study that used carvedilol and has shown good response. So basically, it's to blunt the effect of the catecholamines on the heart because it's been shown that in as much as the catecholamines is trying to increase heart rate and stroke volume, but it also worsens the cardiac state because of the increased oxygen consumption, and this heart is not able to meet up with that. So beta blocker is also very effective because it reduces the oxygen demand on the heart and minimizes myocardial death. And then aldosterone antagonists. Example is the spironolactone, which we readily use. So by the time you have a child with mild symptoms, starting from class 2, you may want to introduce it. But a child who is not in heart failure, you don't need to. You just start with ACE inhibitors. Then the diuretic therapy is
Okay,
actually
so like
paused.
on spironolactone also, in addition to the anti-aldosterone effect, you
It also
realize
has a
that,
diuretic,
yeah, so because it
weak
directed,
diuretic.
yeah, but usually these children would have been on loop diuretics for some time and would have been losing a lot of potassium if they've
Yes,
been on loop diuretics for quite some time. So the potassium sparing effect of spironolactone and the anti-aldosterone effect becomes necessary for these children.
yes, it becomes necessary, and generally, it's shown that it's not supposed to be continuous use.
Mm.
It's paused,
Yeah.
depending. Okay, if you have congestive symptoms, you use, but that means you have to keep the child very closely. Although in our environment here, it's something we just give routinely
Yeah,
because we
but so
know
we follow up
presentation.
closely.
Yes.
Yeah, we follow up closely. Yeah. It's all
All
right.
right.
Okay,
So
thanks.
the
So
other things that come in between, actually, by the time the severity is increasing, IV and nootropic support and mechanical support devices.
it's all right. So, our dear listeners, we've done some justice to the pharmacology of heart failure treatment, and I just want to be sure that you can still hear me loud and clear. Fine. So, we will now proceed with more sophisticated ways of treating heart failure. Like I said, the previous slides talked about pharmacology. So let's step up a little further to the things which this center will soon start doing. All right.
Okay. This is called an implantable cardiovascular defibrillator. Basically, it's a specialized pacemaker, and it's a procedure. It's a surgical procedure, no doubt, where you have an implantable cardiac defibrillator just beneath the skin, and you have some electrodes or leads, electrical leads connected to the heart. And basically, it's a procedure that is common with adult use. It's not so common in pediatrics. It's something that's just gaining grounds, but there are indications um, for some of these procedures, and it actually helps to defibrillate. Basically, as the name implies, it picks the if there's an abnormal reading, it picks it and then it addresses it just immediately.
Okay. So hold rate and reading bradycardia here and then abnormal reading.
Yes.
Okay. So
Okay, this is
ventricular.
another procedure. It's called ventricular assist device. Basically, the ventricular assist device is like a mechanical heart. And then this is usually in advanced, this is useful in patients who are already in advanced stage, who have met the criteria for transplant, but they are awaiting transplant.
Yeah.
Yes. So like if we see here, this is the device itself. So this is the outflow cannula. Like this is the outflow, this is the aorta. This outflow cannula, the blood, okay, it starts from here, from the left ventricle,
Yeah.
it drains it because it tries to relieve the heart. The heart is not even able to pump.
Yeah.
So it just relieves the heart. So it drains whatever blood is coming into the left ventricle. It does the pumping. This is the machine itself that does the pumping. And then it pushes it back into the aorta. And then this distributes it to the systemic circulation. So the machine basically has taken over the action of the heart. So it's actually called a mechanical heart.
Wow. So help me God. It's all right. So yeah, this is after the mechanical heart. This is now heart transplantation.
Yes, and like it's shown here, it's a failing heart, and you have to replace the new with a new heart. And then, but the truth is, everything has risk. So most times, what you measure the risk and the benefits. So heart transplant comes with its own risk, and that's because apart from the risk of the procedure itself, it's something that would require a lifelong immunosuppressant medications, and there are several other things that can come with this risk of infection and cancer and even kidney problems. So there has to be strict criteria to be met for someone to be asked to go for a heart transplant.
Looking at this, I think there should be more enlightenment in the medical world on preventive cardiology.
Yeah.
Preventive cardiology. So
Especially
because
for us
so rheumatic heart disease. So the appropriate treatment of pharyngitis prevents rheumatic heart disease. So you preserve heart valves, preserve the heart from getting up to this point. This is really a serious matter. And then those who would have some shunt lesions, devices can close some selected shunt lesions. So the earlier they are treated,
the better, yes. So because once the complication starts setting in, it's not funny. Really.
Yes.
It becomes very expensive,
Yeah.
and then you are not certain you will get the required results.
Yeah. It's okay. So these are
some of the
indications.
Cardiomyopathy, especially if it's congenital, cardiomyopathy generally, and then anatomically uncorrectable congenital heart disease. What readily comes here is the hypoplastic left heart syndrome.
Yeah.
Although there are, in recent times, there are some procedures you can do to buy time, like the Norwood procedure. It just helps you to buy time for the child. But ultimately, the child will require a heart transplant. Then refractory heart failure after previous cardiac surgery, especially when the surgery was not done early, once complications start setting. At that point, even if you do a surgery, it doesn't really change much in the child. So unresectable symptomatic cardiac neoplasms, and then refractory ventricular arrhythmias. There are some other indications, but these are the main ones.
Yeah. Okay. Yeah. So this is just to emphasize the previous.
Yeah. So I think the whole essence of this is you want to optimize. Cardiac transplant is not an easy procedure. So if you have to do it, then be sure the individual needs it and be sure the individual will benefit from it. Because a number of times you have a lot of people on the waiting list. So you don't want to give it to someone who eventually seems like he just got wasted on the individual. So you want to be sure that there are no contraindications to heart transplant in that individual. So pulmonary hypertension is one, especially irreversible pulmonary hypertension is one of the contraindications to heart transplant. Like we discussed earlier, except you are ready to do a heart and lung transplant. Yes, because if you do a heart transplant at that point in time, because of the damaged pulmonary vessels, there will always be secondary affectation of the heart, and you are back to square one. So multiple system.
Yeah, so on this elevated pulmonary vascular resistance can occur both in multiple causes pulmonary hypertension, primary pulmonary hypertension, those from left heart problems, shunt lesions, even children with sickle cell. It's been found a recent publication that 1 out of every 4 children with sickle cell could have elevated pulmonary pressures. So these things, we can take care of them at an early stage for children, and we don't get to this level.
Yeah. Okay, so multi-organ system failure, as it is, there's failure of other organs.
Yeah.
So singling out the heart to transplant doesn't eventually take care of the child's problem.
Yeah.
So in just transplanting the heart, if the child still has some other organ failure, the heart will eventually join them. So you don't, like I mentioned, you want to give it to an individual who would benefit. Yes. So a major central nervous system abnormality, what readily comes to mind here is an encephaly. You have a child, you know the prognosis is poor, so you don't want to heart transplant the individual. Same for a child with severe dysmorphism who has major congenital abnormalities, several major congenital abnormalities, and then life of the prognosis is bad, it's poor in that child. So you don't want to be quick to do a heart transplant in such individual. And then marked prematurity, small size, basically it's still just optimize the heart transplant so that you are sure you are winning, not to transplant and then you lose the child just shortly after.
It's okay, fine. So we would like to know back heart failure. What something caused the problem, the child has tilted to heart failure. If heart failure is not treated, it can lead to another problem. So what?
Yeah, so complications can set in at any point, and then we mentioned earlier a child with congenital heart disease who is already or is at risk of a chronic heart failure, and because of the congestion, pulmonary congestion, and then these kids mostly are malnourished, they have reduced immunity, so they are predisposed to recurrent pneumonia,
Yeah.
and then there's something called cardiac cachexia. Cachexia means someone who is malnourished, basically, and when it's now of cardiac origin, so you say it's cardiac cachexia, and pulmonary
So
edema.
it's one thing that immediately comes to my mind from undergraduate pediatrics is endomyocardial fibrosis,
Yes, yes.
EMF. It's okay. Yeah.
Okay, so pulmonary edema, congestion within the lungs, and this seems to worsen the cardiac failure. So if this is not addressed, it can lead to pulmonary failure in addition to the cardiac failure and then worsen prognosis in the child. Cardiogenic shock too can be a complication, especially for a child who had had a background of congenital heart disease. And then stroke, especially for those who had dilated cardiomyopathy who are at risk of thrombus formation. So this there can be embolism of some of these thrombi, and then the individual comes with stroke.
Yeah.
Cardiac cirrhosis, that is actually cirrhosis of the liver of cardiac origin, and that's because of the backflow pressures from the heart. There's persistent or chronic congestion within the liver, and this over time causes cirrhosis of the liver. And then some other organ failure, there's something like the cardiorenal syndrome, still because of the low cardiac output state. So there's affectation of the kidney and some other organs. Then arrhythmias too. It's, arrhythmias can cause heart failure. Heart failure can cause arrhythmia. So commonly you can have the ventricular tachycardia, ventricular fibrillation, and then sudden death.
Sudden
Yes,
Hmm.
it's something we don't like to
Yeah,
hear.
no one's here
The
because it
possibility
triggers.
is there, and that's why we have to do whatever we need to do to keep these children alive.
It's okay. Good. So, dear listeners, we want to discuss a practical case that we handled in our center. Having seen the presentation, the etiology, the classification of clinical severity, the management, let's wrap up with this case. I think it should be interesting. So, a 2-year-old boy who had Down syndrome phenotype had a repair of endocardial Cushing, complete endocardial Cushing defect before presenting. That was surgery was done 2 months before presenting to our center, but it had become complicated with pulmonary hypertension even before the surgeon went in. And that's one of the issues about heart transplant. And in this case, the child would have benefited from a heart-lung transplant. Now, we saw the child with complaints of cough that lasted for 10 days. Well, cough in Africa, in Nigeria, cough can be anything. But by the time the child tipped into fast breathing and darkening of the palms and soles, the parents presented within 5 hours of these symptoms. Now, the child was acutely ill looking with mongoloid facie, was in obvious respiratory distress, was sinus centrally, conjunctival suffusion. Child was febrile, with temperature of axillary temperature of 38.3 degrees centigrade. Child was not dehydrated. For the child's age, the child was tachypnic. He had pectus carinatum with a median sternotomy scar, had vesicular breath sounds and transmitted sounds. Surprisingly, the oxygen saturation was so low, 53%. Well, the child was tachycardic, apex beat was displaced, child had the first, second heart sounds, the loud P2 component, and the grade 2 pansystolic normal maxima at the lower left sternal edge. Significant finding on abdominal examination was enlargement of the liver of 4 centimeters below the right costal margin. So, admitting diagnosis was severe heart failure based on the ROS classification for age, secondary to bronchopneumonia in a child with AV canal defect and pulmonary hypertension who had had surgery done before that. Well, the child was nursed in propped up position. We quickly did an electrourea creatinine full blood count, but this was essentially normal. Child was commenced on intranasal oxygen as supportive care. Feeding was optimized. We made sure we avoided fluids. Now, fluids would be a problem in this case. Even if it's just a pneumonia, you wouldn't want to flood the lungs. Now, the child even has a cardiac component. So feeding was optimized, and we nebulized with saline because there was so much congestion, nasal congestion, mucus, and desperately. We gave antibiotics, furosemide, spironolactone, sildenafil. Well, this is the chest X-ray that we have here. You can see bronchonodular opacities on both lung fields and an enlarged heart with biventricular configuration. The cardiothoracic ratio here was quite large, so from chest X-ray alone. Now, echo was done, and the child had pulmonary hypertension. The tricuspid regurgitant velocity, which shouldn't be more than 2.5, we found 4.17. That was really, really large. And then this is a 2D echo of the child from subcostal view. See the marked dilatation of the right atrium. So the right chamber so dilated that the left atrium was really so small. The right ventricle also dilated.
The interatrial septum.
Interatrial
turning
septum,
to the left.
yeah, septum shifting to left when actually it should be straight or at best bulging to the right just a little. Well, the child survived it. After intense care that we did, the child was monitored closely and the child survived the care. But what do we take home from this child that was managed and heart failure in general? Early diagnosis is essential, and echo is necessary for specific patients, for etiology, and on a general scale to check ejection fraction for grading and AV valve insufficiency, also for grading of clinical severity. If they are diagnosed early, classified early, intervention occurs early, would prevent a lot of the complications which my co-presenter has done a good job on, and will also reduce mortality
and improve survival.
and improve survival.
And the overall life expectancy.
Life expectancy. So we hope to give these children good chance of survival, reduce under 5 mortality, contribute to our own quota to the sustainable development goals of improved childcare. Now, this is take home, and we do all this in our center. Manage them basically in the Limi Children's Hospital, and the cardiac patients are cared for in cardio care, which is the cardiovascular branch, specialty branch of the Limi hospitals. We are grateful you were able to sustain attention, having you up to 91 participants to the end of this lecture. We are happy that none of us failed. Nobody failed in between. Thank you. We are open to your questions. We've been able to answer the first question that was posted on the screen, but then we are open to questions, and you can type into the chat box. I'll be very happy to answer you. Yeah. So while we wait for your questions, on the screen you can see our beautiful hospital, the night view. The Limi Children's Hospital at Ademola, 39 Ademola Adetokunbo Crescent in Wuse 2. So we have a covering consultants, yes, in our branch. So you always find a consultant from 8 a.m. to 9 p.m. every day. And even if it's around 2 a.m., consultants on call can step in. The child that was successfully managed was admitted by a consultant at about 9 p.m. and managed successfully. So we have that cover. Because this is a cardiology presentation, I will talk about it first. We are lucky to have 2 consultant pediatric cardiologists who you are looking at from the screen. Yeah, so we do echocardiography for our children, also perform and interpret ECGs, working on modalities of starting even fetal echocardiography, and also there are services for structural heart disease correction is on the way, which will definitely be this year in a short time. We also have newborn care. The next presentation for next month will be on newborn care with heart lesions. So we have a very equipped newborn neonatal intensive care with our ventilators, our incubators, dedicated nurses. So we run intensive care services. We're able to manage children of below 1 kilograms. Below 1 kg. So we usually say, we prefer to say less than 1,000 grams, just to make it sound bigger. So children of up to 8 kg, 0.8 kg have been successfully managed. Surfactant administration is routine for babies that need them through minimally invasive surfactant therapy. And these children have a good lease of life. Good. Now, we have 2 questions. Thank you for the presentation. Why is full blood count essentially normal in a patient with pneumonia and fever? Any explanation? This child came in really early. You see, the child came in. So, pneumonia, yes, is. So, we're looking at sepsis now, but localized to the lungs at the point that it was peaked. I am very sure the child presenting much later, because symptoms will deteriorated within 5 hours. Within 5 hours for the child to have presented. So what we found, full blood count was not suggestive of sepsis in this child. And as a matter of fact, fever was peaked at presentation. So we will still treat pneumonia with antibiotics. Of course, the Paediatric Association of Nigeria algorithm for treatment of pneumonia, you would have a penicillin-based medication there. That's why we started with the penicillin-based and an aminoglycoside, provided we've done the renal function, which was normal in this case. So we treated with antibiotics. It was pneumonia from clinical and radiologic diagnosis, and full blood count would have gotten bad if the child had presented much later. Also, please could you throw more light on the use of sildenafil in heart failure in children and the dose? Okay, fine. So sildenafil was used because the children already had pulmonary hypertension. So sildenafil is, so I've had to prescribe sildenafil for a girl with pulmonary hypertension, and I had someone walk up to me, "Doctor, what do you mean? Giving Viagra to a child and a girl?" It was funny, but that's it. That's sildenafil for for pulmonary hypertension. So it was not primarily for the heart failure. It was primarily for the pulmonary hypertension that was a component of the entire pathology in this child.
So we are still awaiting more questions.
So we are waiting more questions. We are open to questions. It's all right. Okay, fine. So we are grateful you joined us in our webinar. I'm sure you found it engaging, interesting. We shall have another one the 3rd week of May. Yes, talking about bedside identification of congenital cardiac lesions. How you identify it at the bed in neonates. So you meet a neonate, you are able to tell clinically that this child has a cardiac lesion. So we will be dissecting that next month with a lot of our images we've done to make it real life, and images that will stick to your memories. And these children, we hope that as part of Limi Hospital contribution to the overall well-being of children in our community, we will achieve our goal that families will be happy through the great health care we give. Thank you. You follow us on social media, and these presentations will be uploaded on YouTube. And for those who have registered and followed, it is our custom that you will get your CME points sent to the email that you registered, and even the presentation will be sent to your email. So,
and if by chance you don't get it, you can always send an email.
Yeah, you can send an email. We want to be sure you are satisfied. Thank you. God bless you. Yeah. Okay. So end. End meeting.